We're going to talk about hip replacement surgery, more specifically, anterior approach versus posterior approach. So anytime I have a patient that asks me this question, I always tell them the best thing that they can do is go with what approach the surgeon feels most comfortable with. So if that is posterior, if that's anterior, whatever it is that they do the best, that's the approach that you should have. Myself, I do anterior hip replacement. The reason that I like anterior hip replacement is I feel like it provides the patient a little faster recovery after their surgery. The direct anterior approach doesn't cut any of the muscles. It's done through the anterior aspect of the hip, as it says, but it doesn't cut any muscles. The muscles get split apart. All the work is done down inside of the hip, and the muscles, once the surgery is done, the muscles come back together and away you go. In the literature, there's a smaller dislocation risk associated with the anterior approach as compared to the posterior approach. But again, there are many factors that can cause this. I think the anterior approach has a much steeper learning curve, therefore it's a little bit more difficult to learn. But once you get the hang of it, it becomes second nature. It took me about 6 months during fellowship training to get good at the anterior approach. And that's the only approach that I use today for hip replacement. With regard to patient feedback on the anterior approach, a lot of people say that it's much faster recovery than they expected. I can allow them to do whatever they want to do. There are no restrictions following anterior hip replacement in my hands. The reason that I'm able to do that is during the surgery, I have an X-ray machine that I make sure that the components are in the correct position. With my anterior approach, I don't have restrictions. People can sleep how they want. They can pretty much do whatever activity that they would like to do, knowing, that the hip is in the correct way and that we're not going to have any trouble with it. People that need hip replacements usually have failed all the conservative treatments, things like oral medicines, intra-articular injections with cortisone, physical therapy, and various other non-operative modalities. Most of the time, people choose surgery when the conservative things have stopped working for them, and it's really affecting their quality of life. More specifically, as the gap widens between what they would like to do and what they can actually do, people start to feel frustrated. They get depressed and irritable. Either they notice themselves or their family members start to notice. And finally, when people start to lose their mobility, they lose their independence. And so if those things are happening to people and the conservative measures can't help them anymore, then usually we move toward hip replacement surgery. For an anterior approach, I don't usually do physical therapy for the patients. The only thing that I have them do is just walk and move around. I have them set small goals and try to achieve these goals each day. It's not that they're going to walk half a mile today and then tomorrow walk 1.5 miles. It's nothing that dramatic. Something as simple as I'm going to walk 100 yards today, and then the next day I'm going to walk 100 yards and then add 10 more yards. Something that is attainable, that they can see progress on a day-to-day basis. This seems to give people a better sense of their recovery with small goals that are easily achievable without overdoing it. Traditional physical therapy is something that we could do if patients are wanting more flexibility, more strength, or a supervised therapy program, but most people don't need formal physical therapy. As with anything in orthopedics and in medicine, it's best to discuss these things with your operating surgeon. We have many great surgeons here at OrthoArizona with lots of availability.